All right. Good morning, everybody. Welcome to the Changemaker session. Hi, Camilla. Nice to have you from Santa Barbara. Hi, Dennis from San Diego. Lori in LA. Nice to see everyone. Hi, Chaya. I just emailed you this morning. As you're hopping on, go ahead and tell us in the chat your name, what hospital you're from. We would love to see who's represented here. Hi, James from Enlo. Nice to see you. Hello, Jill. Nice to have some of our sons joining today. Hi, Ryan from ASAP. Ryan, I loved your podcast with Alicia. I listened to it twice, actually. We were so glad to make that happen. Go ahead and throw your name in the chat. Oh, hi from Illinois. Yes, represent Illinois. I'm John here at the program team, and I both have some Illinois roots. We won't tell you about the weather here in California. I know you all have been having a pretty rough week. I hope everyone's having a good week so far. Hi, Melanie. Nice to meet you. School's been canceled all week because of wind chill. Oh my goodness. Eesh. That wind chill is no joke. Hi, Felicia. Nice to meet you. As you're joining, you can put your name and your hospital in the chat. We are going to get started right on time today. So got a lot of information to share with you. We're really excited to see the growing participation across the state in California Bridge. Hi, Sylvia. Nice to have you today. Hi, Tammy. Long time no talk. Tammy and I talked yesterday. It was my last meeting of the day. Tammy from Vituity. Oh, hi. Orange County representation. Nice to have everyone. There's Vallejo. That's Ariana's neck of the woods representing California Bridge. I'm so glad to have resources from Solano County. Solano County was not represented in our first round of California Bridge, and we had a lot of patients identified in Solano County who ended up having to go either to SAC or to Alameda County. So really, really glad to see the resources growing in Solano County. Yeah, Oakland, represent, right down the street from me, Clinica de la Raza. All right, good morning, everyone. Hi, Camilla. As you're jumping on, little programming note here. I'm realizing you actually in the chat want to click to panelists and attendees. I will see everything, and I'm monitoring the chat here today. But if you do want other folks to be able to weigh in on questions that you have, you'll want to go ahead and click to panelists and attendees. So yes, nice to see everyone today. All right, friends, we're going to get started in about 1 minute, minute and a half. So if you want to grab some water, another cup of coffee, no judgment from over here. O'Connor Hospital. We're so happy that Santa Clara Valley is able to expand this program. They were our superstars in our first round of California Bridge. Hi, everyone. Good morning. It's about that time. My name is Elizabeth Keating. I am the Clinical Program Director for California Bridge. Thank you for making the time to join today. We're going to get started with Ariana Campbell and Josh Luftig. And as people jump on here, they are going to walk us through the California Bridge model. And if you're thinking, I already know what the California Bridge model is, maybe I've been involved in it for a while, I know that every time I hear Ariana talk about it, I find something new to latch onto in terms of why this mission matters. So Ariana, why don't you go ahead and kick us off, or Josh, and whoever's going to talk first, go ahead and start reminding us why we're here as people jump on the webinar today. Good morning.
Sure. Good morning. So I am
Ariana, actually, Lori, we're going to address that within the first 10 minutes of the session. So just sit tight. Thank you. The question was federal officials announced the plan to drop the X waiver. We're going to talk about it. Sit tight. We got you.
Yep. All right, so I'm just going to get started. I know we have some folks who have attended presentations that we've put on before, and also some folks who are new to California Bridge. So I am just going to start by going through our model just so it's pretty clear. And really what we're planning to do today is, we had two previous sessions on really how to elevate that hospital champion, how to find that hospital champion. And I know I watched that. That was Reb and Alicia who did that, and that was great. And then we had Les and Kevin introduce more of like the system. And, what we're really doing today is expanding on how to empower your son and the hospital champion to really come up with a system that works. Some of what we talk about is, like our goals. Like I'm still working on this in my hospital on a regular basis. So it's not that you start out this way or have to have every piece in place. I started by just getting Bupe on formulary and giving it at the right time to the right patient. And that really opened the door to seeing how we can improve care so much more. So I'm going to get into just a little bit about our model. So next slide, Josh. I was just going to say, we have no disclosures, just, folks always think we do, but we do because we talk so passionately about this and believe in this treatment so much, believe in this model so much, but neither Josh or I have any disclosures. So if this is our model, you may have seen this before, and maybe this is new to you, but what we believe in is very rapid evidence-based treatment. So getting treatment to patients very quickly, 24/7 in our emergency departments and hospitals, and then connecting to care. So making sure we're connecting to high quality care, just like we would do with any other medical problem. We want our patients to be able to continue the treatment that we start in the emergency department and to feel good about this and to be respected. And that gets into our culture of respect. So we call it a culture of respect. And where we've also landed, and I'll get into this a little bit more, is it's also sort of this harm reduction approach to medicine. So next slide. So again, evidence-based substance use disorder treatment. What's funny is when I talk about this, sometimes people say, we're not doing that already, but I'll talk about that a little bit more. Many places have not. I didn't know it existed until it was presented to me and I was able to educate myself. So it is important to just shift the paradigm to treating substance use disorder with the same type of treatment that we do for other medical problems, looking at the evidence and what works. So we talk about that all the time. And of course, that's buprenorphine in the emergency department to start patients who are in opioid withdrawal, in treatment. And for those patients, also sometimes methadone. But our focus is on buprenorphine because it's really quick and easy in the emergency department. And then in all other hospital departments too. So really expanding this treatment so it's what a patient can expect when they show up. Next slide. So connection to care. So we always hear about this. Okay, we could do this in our department, but how do you connect to care? Just making sure, and this has been addressed in actually the previous session. But linkage to ongoing care, it just means that you need a connection to an outside clinic where they're really continuing the type of treatment that you start in the ED. So having an expectation of quality, low threshold, low barrier care in the clinic, and actually going out to people who use drugs to increase access to care, to increase access to harm reduction type of services, to really make sure we wrap our patients in care just like we would other medical issues. So next slide. And then culture. This is, I think, where a lot of us who have done this work. So you start out giving the medication and making sure your patients have follow-up. It's kind of fun to actually see how many patients really follow up because it's amazing how many patients really want care and really seek that follow-up. But hospital culture really does change once you start these programs. So we want the hospital culture to be welcoming, so we do not stigmatize substance use, but we're grateful that patients are showing up and asking for treatment and engaging. So we build trust. We're rebuilding trust in this community with people who use drugs so that we provide high quality care. And we really are starting to call this more of a harm reduction approach as we have moved through this space. All right, so I just wanted to present that model as quickly as I could. We're going to get into things a little bit more, but now I'm going to turn it over to Amy for the burning X-Waiver questions.
Thank you so much. Boy, this has been a whiplash. So those of you who have not followed this saga as closely and intimately as I have, this was a huge day. So we have been advocating to get rid of this X waiver barrier, which I know that you all struggle with, to essentially X the X waiver. And so this has been a long-standing effort. And essentially, all of the lobbying efforts, all of a sudden, January, last week of the Trump administration, the HHS announced that they were going to rewrite the regulations to remove the X waiver requirements for hospital-based physicians, which would have been an enormous change and really a huge revolution. However, shortly thereafter, we changed administrations, and the Biden administration has indicated that they do not intend to rewrite the regulations as they had announced just prior. It's unclear if this is a pause. There were a lot of regulations written right before the administration changed, and if it's just a pause or in a delay until they get a new HHS secretary in there to take a look at it, or if they really don't believe that this mechanism is valid. It is possible that they feel that it requires a legislative change and can't just be a regulatory change. Biden has indicated support for Xing the X waiver in the past, so I'm super optimistic that we still get this change. However, right now, the X waiver is still in place. So right now, there are no completed regulations that say you can prescribe without an X waiver. However, I think this is going to potentially happen. And so the best thing to do is to start this conversation with your pharmacist, because even if the light bulb changes again and they pull the X waiver, we all know that there's really hard work to do with our pharmacists to make this change. So I think the right move now is to really continue to reach out to your pharmacy and plan to make this implemented as quickly and smoothly as possible. We have a blog post that is linked to the chat. Because things are changing so rapidly, there's new stuff that's happening. We have a blog where we're trying to keep all the most updated regulations and things that you're going to want to know on that blog post. Happy to answer questions. Whiplash. I mean, it's just been a wild month.
Questions. You can use the chat feature to ask questions. This is really important. So we want to make sure that anything people are wondering about is addressed.
Anyone wants to know the sordid backstory, email me. I'll let you know.
Amy, why don't we move on to the next slide? And then if people have questions, we can take questions about both topics at once.
Okay, we also get a ton of questions about sustainability because a lot of our work we know has been funded by grants, and you guys have done such an amazing job pulling all of this stuff together without permanent funding. And we know this, and we recognize that this is a huge challenge and that this is a problem that we need to solve because the work that you're doing is so very important. So we're constantly working on new potential funding sources that would be permanent to really support the amazing work that you are doing. I do have really exciting news. There is a new procedure code. So this is a procedure code kind of analogous to sewing up a laceration or any procedure that would be done in an emergency department. It's in addition to the regular E&M codes where you would bill for a level of service. It's on top of that, which is fantastic news for us. This is procedure code G2213. This is also going to be in our blog post. This is covered not just by CMS, but also DHCS in California has agreed to cover this as well. The exact documentation requirements have not been outlined. However, if you read through what the code covers, it's pretty straightforward, and it pretty much is what we're already doing. You have to document that this is indicated. So in some way that the person has an opioid use disorder, does not require DSM diagnosis. that in some way that person would benefit from buprenorphine, that it was administered or prescribed in the emergency department, and that person was referred to ongoing care. Pretty much exactly what you were doing. This is live now. You can bill Medicare, and it is covered by our Medi-Cal patients, our Medicaid patients in California. So really fantastic news. We're going to continue to push on all the levers to make sure that your work is supported as much as it should be. But fantastic news that we have this code and it is live. And I think that's just a huge recognition to all of the success that you guys have had. So really, thank you.
So
Amy.
Oh,
let's
so the 3-day rule. Okay, this is really interesting. There was a law, and I don't want to derail this whole piece. There was a law that was stuck into the CURES funding that went through this December. And the language said that the DEA should rewrite the regulations to allow dispensing of a 3-day supply of buprenorphine. The DEA has until sometime this summer to rewrite those regulations. They have not been written yet, so that is not live. There are specific challenges in California, as you know, around dispensing controlled substances. We got a lot of regulations around documentation and labeling that we're working through. Separately, I think your question is the best. It would be best if we could just prescribe a 3-day supply. So hopefully working with the DEA in their final regulation for there to be a wiggle room where you could dispense or prescribe 3 days, that would be much easier to implement in California. So lots of movement, lots of cool stuff happening. The only thing that is completely live is our EDMAT code. Anything else?
Other questions?
Check out our blog post because that's where we're going to put our most up-to-date information.
Amy, I was going to ask you a question that I've been receiving. Maybe you can expand on this just a little bit. The documentation required for that code, is there any clear?
So the documentation has not been prescribed by either CMS or DHCS. We've reached out to DHCS for clarification. ASAP, the American College of Emergency Physicians, released an FAQ, which we're also going to link to, but they did not have specific documentation like words that you had to put in your note. So I think, and based on their guidance and everything I've heard, it's pretty much as long as you document that these elements are covered, you should be fine. But also this is one of those things that is going to come down to your billers and coders. I met with mine and we're actually going to, to indicate this, write EDMAT procedure so that it is all documented in one place to make it easier for the billers and coders to identify. But I don't think it's, they haven't said you have to say these exact words.
Do you see it as being as straightforward as using heroin 1 gram per day, started on buprenorphine in the ED, given a prescription and linked to XYZ clinic like that?
Yes.
3 sentences could potentially be, okay.
Yes.
Other questions? How to prescribe and how to get paid. These are the 2 most important things that we need to know about. So pause for another moment for questions. And please know that you can reach out to us at any time with more questions about this. We'll have somebody get back to you.
Super exciting. Really lots of cool new updates and things happening. So it's really fantastic time.
Okay, good. So thank you, Amy, for making yourself available to tell us about these important regulatory pieces that we're following. And I will turn it back over to Ariana and Josh for regularly scheduled programming.
All right, sounds
Thank
great.
you.
Thank you so much, Amy. I know those are all the burning questions. I think actually, Elizabeth, we were going to talk a little bit about our new website and the resources.
That's true. That's true. So just so everyone knows, we have completely redone our resource page and we are really proud of it. So please, we'll have that page in the chat, cabridge.org/resources. It has some really useful filtering functions. So you can filter based on the topic that you need resources on. There's a tremendous number of protocols and guides. And then the one feature we really want to draw the folks on this call's attention to, if you can go to the next slide, please, is that we do have a feature on the website. Go to cabridge.org. You can click on shift, and it is a streamlined page for what prescriber might need while they are on shift. No time to sit down and do research into the best treatment modes. Just go to cabridge.org, click on shift, and those resources that you need to work with patients in real time are there from a phone or from a computer. So please take a few moments, go through those resources. Your California Bridge Regional Director can also do a walkthrough with you of these resources to determine which might be the most relevant to your hospital. And if you are not sure who your California Bridge Regional Director is, just send me a message privately in the chat here and I'll make sure you get connected. Now I will turn it back over for our regularly scheduled session.
All right, sounds good. So Eric actually Hill is on this call and he's probably sick of seeing his own picture. So I'm just going to put that out there. But what I wanted to talk about, so just to introduce myself, I think I know a lot of people on this call as I've been doing this work with California Bridge for a long time. I think it's important though to establish I'm Ariana Campbell. I was formerly Samson, so I confused everything and changed my name. I am a PA in the emergency department at Marshall Medical Center and one of the founding members of California Bridge. I am very passionate about this work and talk about this all the time. Before I get into this picture, I also wanted to introduce Josh Luftig. Josh.
Hi, yeah, so I'm Josh Luftig. I'm also a PA in the emergency department. And like Ariana, I've had 20 years of clinical experience and then have been on the journey of going, no way are we offering a methadone clinic out of the ED. This is not what we do. And I've gone through the journey of now just completely engaging this entire realm. And then have been on the front lines of seeing, we've had thousands of starts from the ED at Highland Hospital in Oakland, where I work, and then also working with other hospitals and hospital systems across the state and seeing all these sites are like, oh, we can't do this here, and oh, we can't do this here, and then just seeing that journey as sites set up their programs. It's been amazing.
Yeah. So I have a similar story, and I walked into a meeting, I always say, and somebody told me that I should be giving buprenorphine in the emergency department for opioid withdrawal, and I just said that's not an emergency department thing. And I said a lot of the things that I hear from other folks who are starting programs are a little hesitant. And so that was my journey. I worked for 17 years in emergency medicine before I adopted this program. So I have that similar experience. But once I started, we're going to present this whole program that is amazing. What I want you to know is that I just started by getting buprenorphine on formulary, having a patient who came in opioid withdrawal and giving her the right medicine at the right time, then listening to her about how she felt with the medicine and if I was giving enough or if she needed more. So it just started there. But then we're going to talk about how we've evolved into a program. So how that evolved over a couple of years is we did not have a substance use navigator for the first couple of years of our program. And we got Eric Hill here, who is amazing and completely transformed culture and everything. But this picture, I took this picture. I was standing there so proud because Eric had worked to get this sign in our lobby, which a lot of places that are starting programs may understand that it's not always easy to get this sign through marketing and all of the different channels. And so we had this sign. It's the first thing you see when you walk into our emergency department, into the lobby. So I'm standing here taking this picture of Eric. And at the same time, I actually have a nurse saying, why are we putting that sign up? I don't know about this program. And we had done this for 2 years and we had been in multiple big publications about our work. But my nurse said, I don't know what you're talking about. I don't feel comfortable having this sign up because I don't know about this program. And then I heard the same thing from registration staff and other folks. And I thought, oh, I failed to actually, really get the message out to my entire team. So this looks like a big win picture. We were so excited, but really to me, it was a humbling moment where I realized that we could improve what we were doing. And we really needed to look at the stakeholders in our hospital and in our emergency department so that we could figure out who needed all of this information so that we really could improve care. And what, I know Eric can't talk right now, but we expanded what we were doing. I think we treat at least 3 or 4 times the amount of patients that we started with because of the work that he's doing, because of signage, because of engagement of our whole department. And it's something that we've become very, very proud of. I had the same concerns that Josh had in the beginning, and none of that proved to be true. And in fact, it was transformative, not only for patients, for our emergency department, but for me personally, in terms of facing things that didn't feel good in medicine that were making me question my career. And then this was sort of the spark that made me feel I could do something really great for patients. And that feels good. We all got into medicine for that. All right, so next slide. So this is a case I like to start with just because I think it's important to see what you do in your emergency department now versus what you can do. So 28-year-old man snorts 2 grams of heroin a day and is now in withdrawal. He states that he feels very sick and needs help. What does your hospital do now? I want to start by saying that this same patient, if they come in and they're telling you that they're using heroin, how they're using, and that they feel sick and need help, you've already done a good job. You've already made them feel like they can tell you this, right? So this is a win before you do anything, because we have previously created an environment where patients did not necessarily feel comfortable telling you this, and maybe you didn't even know or have adequate treatment. Sure, we all tried with clonidine, Zofran, supportive medications, that list that I always talk about that you hand to patients, and it has all these clinics, in my experience, that weren't very helpful because I didn't really vet them. I didn't really check them out first. So just the fact that this patient's coming to you and saying this is a huge win. And if you don't have a son, or you do have a son, just think of what this looked like before you had that son, right? So, and then when you do have a son, and when I say son, I mean a substance use navigator. If you're not in California, this is like a peer navigator, or there's various terms for this across the country, but our substance use navigators are really key to building up these programs and to making our patients feel comfortable and connecting them to care, and quite frankly, doing the work that takes a lot of time and effort that is very difficult for ED clinicians to do. Josh, what was your program like before you had a son?
Well, I think one of the challenges was there was not, among the many challenges was we didn't have a good way to get people into care after they left the ED, and someone to continue to sort of move forward with the patient over time after that ED visit event, to coach the patients and make sure they got their appointments and remind them of appointments and troubleshoot the pharmacy and all those issues. So we would send patients out and they would just fall, they wouldn't be able to make it to the next step. So that was one major piece. And then the other, of course, and then I'm gonna go into each little piece in terms of like the entire patient flow, the patient journey, and how the sun interfaces with all that in upcoming slides.
Yeah, and I start there because sometimes you look at the system that we've developed, and I don't want those who are new to this to be intimidated. This is what we're setting up, because this is where we've landed. And what I'm trying to do is help others not make the same mistakes that I made, because you can avoid a lot of heartache if you learn from
Right.
learn from us. So yeah, next slide. All right, so really the most important thing that I started with, in fact, the conversations I had with nursing staff, with our triage nurse, with actually, we went to every single department in our hospital eventually. The prime message that we wanted to get across is this: that addiction is not a moral failing. It is a chronic disease that requires medical treatment. And I expand it further, that it's a chronic disease that requires medical treatment, but we have acute emergencies that are experienced by people who are suffering, effects of addiction, whether it be abscesses, whether it be other medical issues, or withdrawal itself. And to put all of that into a box that not only is this a medical emergency, that we could treat this, and we don't just treat this in our emergency department, we treat this when a patient may be admitted for some other reason, because it's part of treating them just like you would treat their diabetes if they were admitted. So really making sure that everybody's on the same page, that addiction is not a moral failing. We can treat this, and this is something that is evidence-based, has evidence-based treatment. We have a lot of information out there. It's just a matter of providing the appropriate education and starting with this as a base that can really transform care in your department, and to really find those engaged stakeholders who can make a difference.
Ariana, as we move on to this, what is a son? I wanted to just draw your attention to some of the questions in the chat so that we can answer them as we go.
Sure.
Talking about the difference between a peer recovery specialist and a son. A new son recently hired. Ashlyn, I would love to hear what hospital you're from, if you want to put that in the chat. Ashlyn, a new son, says, what do you mean by troubleshoot the pharmacist? And then we also have a question, are sons employed by the hospital? Which is something that Josh can potentially speak to well. So I want to make sure we get all those answered as we go.
Yeah, sure. So I'm actually going to talk specifically about what a son is. And so substance use navigator, we can define that a little more, but this is and we're going to go through exactly all of the steps that a son, we called it a son because we're California, and so we thought that was really, it's catchy, but it really is like a peer navigator, not always peers. It's just really somebody who cares about people who use drugs, who want to help them get the care that they need and deserve. And you know, this is a person who is a role model for change in the emergency department. That's what we've seen. Eric, my substance use navigator, has conversations with patients that we never felt comfortable having in the past, but they're refreshing, and they're incredibly important, just even through a harm reduction approach. So our substance use navigators will reduce stigma and biases just through the work they do, and through education. Really, our substance use navigators are part of the emergency department team. So there are different employment models. So some are employed by the hospital, some are employed by a staffing group or a contracted group. I know mine is they are part of our hospital. They're employed by the hospital and part of our emergency department staff. And our substance use navigators, it's really important that they have regular check-ins with the champion. So I talk about this because this is how we build up our sons. So I presented that first slide because when I had Eric standing there, with this sign, what I can tell you is that I did not build him up enough. Like, I needed to introduce him to triage staff. So they are really, it's like a knee-jerk reflex where if somebody comes in seeking care, they need, they know to call Eric and have Eric come in very quickly. Eric actually meets people in the lobby that he's been talking to before they ever come to the department. But again, we'll talk about that. But it's really important to have the champion. And we talked about the hospital champion in the last couple of presentations, but that's, a very dedicated clinician who believes in this work and who is trying to build their program in their hospital. And yeah, Josh?
I was just going to say that, and part of it, the son is highly trained in by California Bridge. So we offer initial training and then ongoing support with mentors who are sons, experienced sons. So they have this they tap into this wealth of knowledge that they're initially trained with, and then have ongoing training and support so that they can bring expertise to the situation. So that's just another sort of component of what the specialized knowledge and abilities that the son has that add to the emergency department treatment team. And then as far as using, the staffing vendors, so yeah, I mean, just again, the direct hires are fantastic. And then for sites that are struggling to do a direct hire for various reasons, then using a staffing vendor is also amazing. And we have partnerships with staffing vendors and can connect you to good resources along those lines as well.
And I do see, I wanted to answer a couple of the questions also in real time. So somebody, Jennifer asked, would a peer recovery specialist or someone who has their own lived recovery experience be similar to a son? Yes, yes and no. So we don't require lived experience, but it can be helpful sometimes. And it's up to each individual hospital. It's not required. What we require, the qualification is to have this passion to help people who use drugs and to feel comfortable in that space, and to also be able to connect with folks who are coming into the department. So it really does require those skills, but we do have a job description, and we have an entire hiring guide for substance use navigators that on our website. I know we shared some of those resources, and I'll actually, I have a QR code coming up to answer that question as well, so you can find out the other qualifications. And then the other thing I just wanted to address right now is when you talk about troubleshoot the pharmacist. So for us, we realize that a lot of times you have to have a good connection with your pharmacy just to make sure that buprenorphine is on formulary, and to make sure that it can be easily ordered and administered in the emergency department and hospital. So, and I think we answered those so far, but we'll keep going and I'll answer other questions as they come up.
Yeah, a few more questions, Ariana. I just want to pause for. It's so important that we all begin with a shared understanding of what this position is. So I'm hoping we can briefly discuss what are the pros and cons of making this a part-time position. And then we also got a question, what is the training for a starting son? And instead of going into the details of the son training right now, what I'll say is California Bridge has a formal training series for sons that begins every month. So whenever you have a new son start, we can loop them into training, including connecting them to a mentor who will work as their coach. So in short, when you have a new son beginning, please make sure to connect them with us as soon as possible, and we will get them started.
Yeah, really what we've built is this huge community of substance use navigators of sons who have support all over the state. This is not always super easy work. From what I have learned from our sons, it's extremely rewarding work, but you are completely supported, not only by your hospital champion, which we're going to talk about here, but by other sons across the state, by the California Bridge program. We have your back, really. So, and in fact, most of the barriers, I think almost every barrier we've seen already, and we can help you work through it. So we've done this already at 52 hospitals across the state, and we're now doing this actively at 208 hospitals. So we have the experience, and you also have a ton of support. Our first substance use navigators really were, they were actually inventing the wheel on this, and now we don't have to reinvent the wheel. We have a lot of training, a lot of resources, and we have some experience in this. So I'm gonna turn this over. Josh is going to talk about, because I think a lot of the questions we can answer when we really get into the nitty gritty, of what this looks like at every level. So we're gonna break it down here, just so it's easier to understand what the son is doing everywhere. So I think this will maybe clear up some of those questions as well. Josh.
Okay, so what we have here, and sort of this is kind of like a framework. So when I think about the son role and the sort of value add that the substance use navigator provides to a healthcare system, it's really hard to understate how impactful it is. At the same time, I think it's useful to kind of break it down into the pieces so we can kind of see all the elements and the ways that the son interfaces with the patient's journey through the healthcare system, and kind of use that as a structure to understand where the son role in the healthcare encounter. So these set of slides coming up now are going to kind of break it down in a stepwise way, looking at each place in the patient journey. So if you have the patient journey and these yellow boxes going across, on the top, it just shows that the son is engaged at each step, or can be engaged, and ideally should be engaged at each step in the patient journey. And then additionally, that early engagement is ideal. So the earlier that the son is involved in the patient journey, the more likely that patient journey is going to be impactful, meaningful, successful, positive, all the things we want to get out of that patient encounter. And then I have, so if you go down the column on the left, there's the son engaged, with the amazing sun coming in, and then there's the sun engagement trigger, and this is going to be ways that you can trigger the sun to be engaged early. We have the patient journey, and then the sun actions, and these are going to be the actions that the sun can take at each step along the patient journey. And then, of course, throughout, the sun is modeling compassionate, destigmatizing language and behavior. So part of the culture change, you're going to have staff members who are using sort of stigmatizing language and behaving in a stigmatizing way, which is kind of the norm for healthcare currently. And the sun will refer to patients as having substance use disorder. They're not saying someone's a crack addict, or they really model proper behavior and language and current ways to engage people with substance use disorder in a way that's constructive rather than destructive. And so that presence is always there. And they also, you may have like a champion and a core set of, say, clinicians and nurses who are really on board with this whole program. And then you're going to have a group that is not at all aware of this program or is not on board with this at all. And then you have the sun is this continual presence of radiating positivity about and knowledge and current thinking, and highly trained in this realm, and they help to bring the rest of the team on board by their regular presence in the ED, and doing all this amazing work that they're doing. So that's sort of the ongoing effect of having the sun present. So we're going to go to the pre-visit step, and let me get my glasses on. Okay, so we have so now starting at the pre-visit, and this is also such a different value add than we're used to in the ER. We're usually like, what is the pre-visit? There's no pre-visit. Like we just hit the ground running. Like there's a patient and we're off to the races. The pre-visit piece that a sun brings, and then who can trigger it? So I'll just kind of go this in a structured way. So who triggers the pre-visit? So it can be patients directly contacting the sun. It can be clinics, your primary care partners who have someone who needs help immediately. You have community partners like Syringe Access Services, your harm reduction partners who find people who want to get treatment, who need help right now. And then other SUNs and hospitals. So SUNs across, we have this network where it's like beep, 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 beep. We've got someone in Humboldt who's coming down to Oakland and we need to connect them to care. Or we have hospitals that are still getting the program going, and they can rely on the SUN at the adjacent hospital to help them find a good resource. And then they're also able to redirect patients to the proper clinic or the ED. So not everyone has to come to the ED. So they can actually, once a SUN is sort of established and in place for a while, they start to know, the local people by name. They're on a first name basis with people who are struggling, and then they are able to get them back into a clinic appointment and save an ED visit. So they can redirect, they can be kind of direct people to the most appropriate care.
And Josh, I was going to add on to that. A lot of the work is done in this pre-visit. I think a lot of the substance use navigators who are doing this work can attest to this. And it's not to keep folks from the emergency department, but it's really patient-centered, right? So some patients say, I don't want to go to the ER. So the substance use navigator can say, okay, right on, I'll get you into the clinic. So this work is really important. And I can tell you that our SUN has a relationship with that patient prior to them coming in, and will frequently, as soon as the name pops up on the board, or even before the patient arrives, will alert us, hey, we have a patient coming in, this is the story. And so you're like off and running as soon as the patient arrives, and it's incredibly helpful. So I just want to add that it's whatever the patient wants. If they say, I need treatment right now, come to our ER. So
yeah, they're making sure they're getting they're on the most appropriate path before things get going. And then they can also greet them. So basically they can do, well, one is they can give them advice in terms of they can reassure them that they're going to get a buprenorphine immediately. So that is, one of the anxieties that, if I'm entering care, I'm used to, my normal experience is languishing in the waiting room and then never actually getting treated for my withdrawal. So they can reassure them that if you can come in, I will meet you in the lobby, and we're going to be able to get you treated quickly. And so that you do not have, in fact, if you can come in, please come in in withdrawal, and don't use 6, 12, 8 hours before, and then we'll be able to give you buprenorphine right then and get you started in the ED. And then they can also, there's all these situations, there's so many, the safety net roles of the ED where, you have someone who is started on Friday night, there's no follow-up clinic appointment till Monday morning, and there's no X-waivered provider to write a script, so they need to come back to the ED for another dose, and they can coordinate that visit and make it, like, come in Saturday morning, 8 a.m. I'll meet you in there, or the staff will know you're coming or whatever, and it's not going to be busy at all. Come in and you'll get another dose, and that'll keep you safe through the weekend. And then so the stakeholders, I'm trying to not click forward. The community at large, so the stakeholders involved in the sort of pre-visit, our primary care, they're so thankful to have someone who helps them with patients who need immediate an induction of basically a rapid start of buprenorphine, the MAT clinics, homeless services, all your partners in the community, sobering centers, syringe access services. And some examples are, you start to develop these relationships with sobering and detox facilities. So they identify people who need to be started on buprenorphine, and they'll coordinate with the Sun. So the Sun will help coordinate that ED visit. So it's just a painless in and out visit, and does an amazing amount of good. Again, the community clinics, and then out of county patients. So that Sun network is so valuable. Anywhere in the state, someone can land and then be referred to another clinic anywhere in the state, and get the local knowledge, where it's not like if I'm trying to get someone in care in Humboldt, I have no idea what resources are there, but I can contact the Sun at that community hospital, and they'll be like, okay, we'll see if they need an ER visit, we'll get them in the ED. If they don't, we'll get them connected to a prescriber and a clinic. It's amazing. I mean, it takes care of solve so many problems. And then again, hospitals without a Sun. So we don't have Suns everywhere. We have 206-ish. And they can rely on the Sun next door. So this happens all the time. We have sister hospitals that are, and they don't have a navigator. They're willing to start people on buprenorphine, and then they can use the Sun at the safety net hospital or the adjacent hospital to help them get linked to care. And then, of course, people entering and exiting the justice system. So you have people they may or may not have MAT at the prison or jail that's nearby, and then people are released, and they need to get, this is incredibly high risk moment for overdose as people leave forced abstinence situations, or if they're in treatment, if they're at a prison that does have, or a jail that does have treatment, but then they need to get connected to outpatient. The Suns can make that all happen. And out of medication, out of treatment. So people who are, there's this whole thing of getting people re-engaging. We know that addiction is a situation where it requires many quit attempts, and that every time someone is willing to come back into treatment, we're so grateful. And they help message that to your entire hospital, where sometimes it's like, oh, they're coming in again? Like, we treated them once and they're done. Like, why would we ever want to see this patient again? And you're like, the substance navigators understands the struggles that these patients have, and they help smooth out that situation. Be like, no, they're just here. This is amazing. We're so grateful that they're able to re-engage in treatment. We're able to get them another script, restart them, and get them going again. It's so important. And then, of course, when there's no X-waiver prescribers, then I already covered that piece, but they can come in for a redose. And then friends and family members. So basically, once your program is going, people are just so grateful, and then they will have they'll tell people about your program. It was amazing. They started me on treatment, and I'm in treatment, and my life is totally different. And then their friends and family members start to engage. They'll directly engage the Sun before the visit, and say, hey, my brother is in treatment and I need to get in treatment too. And then they start to coordinate that whole thing, and it may or may not even require an ED visit, but they're starting to have a huge impact on their community. The other thing is the naloxone. So I have right here these naloxone kits that a lot of the sons are handing out of the EDs. Way to go. And we put labels, I don't know if I can see this, but we put a label that has the phone number of the substance use navigator right on there. So people can get help and start doing that pre-visit engagement. And then syringe access services. Our harm reduction partners in the community have intimate knowledge, tons of experience, way more experience than we do, deep connections, and they're able to, when people are ready to get treatment, they're able to connect to the son in a pre-visit, and so they can start getting to a prescriber and get engaged in treatment. So that's a pre-visit. Now, so we've made it to now the lobby and the waiting room. And this is where basically the engagement trigger in the lobby is the signage. So, and you may not start out with your program with a sign, but when you do get it there, it is so helpful because it reframes the entire encounter. So, and I'm going over here now, over here on the right where it's the example. So you may have patients who have multiple visits for abdominal pain, back pain, dental pain, et cetera. And that is just like, just think back to your last shift in the ED. That is like so many patients that of your day where you're like, I wonder if this back pain is really back pain or if this is opiate use disorder. And having that whole, skipping around, having that, instead of just having this long, dysfunctional encounter that is not getting people what they need, is totally dissatisfying for everyone involved. You reframe this by having a sign. And it's so simple. Basically, people see the sign, they recognize that this is a place where they will be treated with compassion and meaningful treatment, not just, here's a piece of paper, good luck. And so then they're able to actually just disclose and say, you know what, and it may not even be the first time. Maybe this has been someone who's been coming in for dental pain or back pain or whatever miscellaneous pain, and getting Norco prescriptions in the past, or like that whole thing. And then after seeing that sign, they have a moment to be like, wait a sec, I need help. And when they ask for help, then the ED can respond appropriately. And that's a trigger for the son to also come in. So they're basically like, I need help. And the son immediately comes down. And then what the son does in the waiting room is they can start the initial brief assessment, and they can just start to have a little conversation. And they can start addressing what many of our needs that our patients have. If somebody's homeless and using substance and has, out of control heroin addiction, then they may have a lot of needs. They may not have identifying documentation. They may have no insurance. They may have no home. They have no transportation. And the son starts to kind of do this sort of assessment, but also within the context of the substance use disorder that's sort of maybe at the heart of all this. And then the stakeholder for this is the ED admin. So basically, somebody's gonna weigh in on having that sign there. And it's so important, and the value of having signage, so that's a stakeholder that will be engaged.
Josh, there's a question. Do you involve the son with these patients even when they don't ask for help? And it just depends. I actually will ask the patient. I don't necessarily try to send our son in for, because that could be an awkward conversation. Though actually sometimes our sons do look just at chief complaints, and will some, especially I have to give a shout out to Tommy Trevino on this one, who just goes and he'll sit with a patient and just talk to them and not even tell them that he's a substance use navigator, and just say that, he's just a counselor, and just sits down and talks to him, and has had a lot of engagement from folks just from being nice. So sometimes just our sons are, when you're just nice and respectful to a patient, that goes a long way. And I just wanted to comment, Josh, on the signage piece. I remember when I didn't think signage was a big deal. I thought, oh, well, what's a sign? And I can't tell you how many of my patients saw the sign and felt comfortable talking to me finally about it, or sent a family member in because they saw the sign. The sign is really powerful. And when we wear the buttons too, I took the buttons off for COVID, but when I usually wear my button, I've had patients who will be there for a completely different reason and say, hey, I am struggling with this. Can you really help me? And then I do. And that's amazing. So I just, the Sun can really, push that signage piece, but they need the champions sometimes. I know that there's a lot of barriers in a lot of hospitals I've worked with the signage, and the signage is really important. And so that relationship where the hospital champion can really boost that and help get them engaged with the ED administration, hospital administration, marketing to get that done has been very helpful.
And having the so, and I'm also, wow, I just realized we have like 9 minutes left. So the clock is ticking on our talk, and on the patient in the waiting room. So that is a ticking time bomb in the sense when they're in withdrawal, and if they're left to just languish in the waiting room, that's where your Sun can help be like, hey, we need to, this is not okay to leave someone without access to treatment for withdrawal. Like this is, and so they advocate for them getting dosed with buprenorphine, getting that whole thing going, and taking this person from their misery to feeling like a human being. So the next step is the greeter desk and triage. So your Sun hopefully will establish a close relationship with everyone at the greeter at the front end of your ED. So that's the triage nurses. Those are the ED techs that do intake. And the Sun, as Ariana mentioned, that they can monitor the tracking board. So basically they can look for, someone's there for abscess, or they're just saying they're there for Suboxone, or they just have like key things where they're always kind of keeping aware of who might be someone who needs these services. And of course, anyone can trigger the Sun consultation. That's the other thing, is everyone should have a really low threshold. Like right at triage, they're like, I think we should get a Sun in here. And then it's all substances. It's not just opioids. So it's basically anyone who's using meth or alcohol, or every person can use a Sun. There's always resources that they can offer. So think of them as substance use navigators, not just opioid use navigators. And then there's lots of, we know about 28% of our patients have some substance use related disorder related to their visit, which is just a huge chunk of the ED population. And then of course you want to have, the stakeholders that you want to engage are the triage nurses, the ED techs, IT, so the Sun does access the EHR and the tracking board. So the treatment area, once you're in the treatment area, this can be, sometimes the Sun will be there beforehand and kind of like, already doing a COWS score and talking about treatment, doing some motivational interviewing, engaging them on this, patients on this topic, explaining treatment options. That can take a while if someone's never, really understood what buprenorphine is. They're giving, distributing naloxone, clean syringes, doing all this other stuff. And then basically they're sort of handing the patient on a platter. So like if I come in and I see a patient and the Sun's already seen them, it's so easy. They're like, hey, they just tell me that, they just summarize exactly the situation. They're in this amount of withdrawal, they're ready for a treatment, I give the treatment, and then they just become these incredible vessels of knowledge, of specialized knowledge, especially as your site is getting going and people are still, have a lot of questions about buprenorphine and how it works. And the Sun carries all that knowledge with them. And they can also coordinate, like if you have, if you have a clinician who's not X-waivered, there may be someone in the department who is X-waivered. So the Sun will go around and be like, hey, can we get so-and-so to write a prescription? And they're making it happen. They're just making the stuff that would normally slip through the cracks. There's so many patients there's so many missed opportunities, and the Suns are just making those opportunities not be missed. They're making it so that most people are heading out with a prescription, and they make it easy. So the prescriber who's in the department is just like, oh yeah, that takes 2 seconds because the Sun just handed me like this quick summary. I drop a quick note. It's not my patient, but I'm happy to write a script for that patient, engage with them for a second because I already know the whole story from the Sun, and I sent them off with a script. And then they drop a note. The Sun also can drop a little note in the chart so that then that becomes part of the record, and then it's just helpful. The treatment team can rely on that. And then the discharge piece. I have 5 minutes left. Okay, so basically the discharge. This is so crucial. Again, this is where the Sun troubleshoots insurance, pharmacy, MAT appointments. And these seem like small things, but they're huge things. Like the pharmacy stuff is ridiculous. Like there's, you have like, what kind of insurance do they have? What kind of formulation does the pharmacy have? Do they have the strips? Do they have the tabs? What kind is perfect for the patient who is actually uninsured? Should they get the tablets, generic, which are much cheaper, or do they need to, or they're insured with X type of insurance, but only pays for the films? And then are they going to use the combo or the mono product? Does this pharmacy even have this? Like, you start to see all the barriers our patients face every day. And the substance use navigators walk that path with the patient day in, day out. They can be available to talk directly to the pharmacist and troubleshoot these issues. And this is all happening in the background. There's no clinician involved in this, unless like something needs to be rewritten or anything like that. But they're continuing to carry the ball beyond the encounter. Like, the clinician and the nursing and the social work, most of these people are just doing the ED visit and that's it. And the substance use navigator continues this longitudinal touches and care where they make sure that they're coaching the patient. They're checking up. Did you make it to that appointment? Do we need to make another appointment? What's going on? And so they're continuing that support with the patient over time. And then having sort of this after hours set up where, the sun's not there all day, every day. So at 3 a.m., if a patient is seen in the ED, hopefully started on buprenorphine, hopefully leaves with a prescription, then in the morning, when the sun's on duty, they start to engage and follow up and check in. Were they any troubles at the pharmacy, anything like that? So they work through all that and continue, to carry the ball for patients that they're not even seeing in the ED in real time. They also continue this follow up, continuing support. I think that's basically. Oh, then the other thing is, of course, the in-depth MAT resources, and that cannot be. We're like, oh, we just show up at our local clinic, and there's like, they're only on Tuesdays, and actually the prescriber's there, and you're going to have a 2-hour, sort of intake process, and all this knowledge about the actual resources. How many beds are available for males in that are for residential treatment? Like, who knows that? So who carries all this knowledge with them? And that's the substance use navigator. And then I already touched on the pharmacy stuff. So that's sort of the patient journey. And then this slide is this shows basically, the buprenorphine. Why are we doing all this? Why do we care about all that? Why are we connecting people to treatment? And this is a standardized mortality ratio. And when the yellowish is off MAT, and this is the increased mortality ratio. And then on MAT is when people are on buprenorphine, their mortality is so much lower. And you can see these spikes too. The first fentanyl death, and this is when, mortality of people who are not in treatment, and that spikes up there. And this is when we're getting into the 2016, 2017, 2018, when things are just out of control. And this is the mortality rate. And this is what we offer our patients by having substance use navigators, by having buprenorphine, by knowing how to use it. And this is just a very simple demonstration of that impact.
And I know somebody asked about schedule. This is just, so here's the toolkit for the substance use navigators QR code, because we try to be techie. But yeah, so there's, in terms of scheduling, it just depends on your department. We started out with our son there, like I think 9 to 5, and we shifted to 10 to 6, because that was when our patients were showing up and when we had higher volume. And I know some have varied, and even some work from home at various hours. So that just depends. Yeah, I think we're wrapping up right now. So we only have a little bit of time left. I can tell you that the relationship between the substance use navigator and the champion is key. And we have the toolkit, which really does outline all of the things to onboard your substance use navigator, education that will be helpful. And then we are here providing this education. We have we have a director of our substance use navigation program, and we have a lot of educational opportunities. There's a ton of information out there. We are here for you. So yeah, and like I said, your hospital champion, we started there, and that relationship is key. In fact, right after this, I'm going to go meet my son so we can talk about the barriers and things that we need to do. So that should be a regular thing. Some even text once a day and just kind of check in. Some meet once a week. But it's really important to connect with your champion, and any of these barriers that are faced as you go through this, your champion can help iron that out, and is your sort of connection and road into that the culture of the emergency department and hospital. And it can be difficult, but I can tell you, when we went to our CEO and she asked, what do you need as an emergency department like in the next year, we have said we need our substance use navigator. It's changed everything. It's so incredibly valuable to have an engaged substance use navigator, and I recommend just really connecting your hospital champion substance use navigator. And if you don't have one, look for look for resources in the area.
Great. Thanks, everyone. We are at time. Any lingering questions, you can put them in the chat. We'll take a couple extra minutes. Otherwise, Josh, if we can just skip ahead to the next session, which is just a couple of slides down. It's on March 11th. We'll have Race and Amy talking about how to sustain your program, what to do when you use up the $50,000 or $100,000 from the state. So please be sure to register for that. The registration link will be in your post-event email. And any other questions, we're happy to stay for a couple moments just to chat with you. Lots and lots of links were sent over the chat. Anything you need specifically, feel free to reach out to us. We can make sure you get it. We can link you to your regional director, anything that you need. And I hope everyone has a really great day. Lori, yes, if you can chat me your email address, I will make sure that you get those X-Waiver training opportunities. Just want to throw that in the chat right now.
Yep, we're still gonna do those X-Waiver trainings. I have to comment, even with when we thought the X-Waiver was going to be gone, at least for physicians, we were just changing our trainings. Personally, I'm an X-Waiver trainer. I know Josh is. We were just changing them to educational sessions just to help get everybody on board. But right now, that educational session should still be able to get you your X-Waiver. So we'll continue to support that. All right, and do you have a link to a document to use with providers to encourage them to get X-Waivered? We do have information on our website. Is that correct, Elizabeth?
Yeah, we don't have something specifically to encourage providers to get X-Waivered, but what I would encourage you to do, Devika, let me know in the chat what hospital you're from. I would encourage you to have a one-to-one conversation with one of our regional directors, with one of our coaches, to talk about just what the culture of your hospital might be and what specific strategies you might use to encourage those providers. We do find that different hospitals have different barriers, and depending on what your barriers are, we can help you think through how to sell the benefit of the X-Waiver to those hospitals.
French Hospital.
And we're very good. I mean, we do a lot of trainings, and we do we make them entertaining and informational and efficient. So we go through the content. So we love doing training. So definitely, if people are looking for resources, we're happy to help set up trainings.
Yeah, we try to make it pretty realistic for your emergency department setting, because unfortunately the X-Waiver training I took, almost 4 years ago, was primary care based. So we have updated it, and we try to make it very relevant to the appropriate setting.
Yes.
Yeah.
Patty, I see your request. Do we train providers in clinics? We will train any providers who want training. Yes. We are also available to do talks to really any audience. And Josh and Ariana happen to both be based in the emergency setting. I'm speaking specifically to Lupe Gomez Martinez. Ariana and Josh happen to be AED specific, but we do have other folks who are internal med, family med, hospitalists, toxicologists, etc. So if somebody wants to talk to peers, we can link. We're pretty good at matching peers to peers. So,
and that's actually interesting, because a lot of us who do this work in the ED like it so much that we're moving into the bridge clinics too. So just so you know, there is some crossover there between folks who work both in the emergency department setting and in the clinics, because it's rewarding work.
And there's monthly trainings run by Dr. Rebecca Trotsky-Sir, and she operates out of a clinic. Like she's actually, it's an urgent care. So it's kind of like right in the middle between the ED and primary care.
Yeah.
So she's a
And she
great
does them
resource for
Fridays.
anyone who's, yeah, so every month, and we can just contact California Bridge and they can get connected to that training resource.
Yeah, in terms of signage, I saw that I can't get any signage yet either. Amazingly enough, a simple sign sometimes does take some work. So I would suggest having a team of the substance use navigator and the hospital champion who push this through, talk to marketing, make sure you engage your hospital, your hospital leadership in this in terms of how important it is. And we certainly have a template for signage and some resources for that. But talk to your regional director too, because we can help get through some of those barriers. And if you don't have a regional director, just contact California Bridge for support and we'll reach out.
Yes, I will assign someone to you.
Mm-hmm.
I love matching people.
Oh yeah, family practice small clinic. Actually, we formed one at Marshall. We took a family practice, family practice model, and we just built a small clinic, as we call it, the Bridge Clinic, or it's our CARES clinic. Training for that, we do have some, some physicians, some clinicians who have done that, and there's a request. You can request training on our website, so you can just go onto our website, and sure, Elizabeth can direct you to that, and you can request a training, and we are well connected to be able to provide that.
Yes,
So,
just
Lupe.
use the contact form on our website. It's just cabridge.org. You can click on the contact, send a note, and that'll get to me, and I'll get a training set up. Lupe, where are you geographically? If you can throw that in the chat. Just out of curiosity. Fresno, great. Yeah, we'll get Race right over to you. Race or maybe Raul.
Yep.
Yeah.
Perfect. Yeah, Raul would be great. And then
Yeah.
I was going to say, there was a question that we were going to answer live. I'm not sure if we did. Nancy asked, looking at the multiple MAT bridge sites,
we're working on
how
that.
can she how can she tell where there's a sun and who doesn't have a sun on the website? So we're working on it. It's in process.
One thing I'd like to mention too is that I mean, the beauty is of the ED Substance Use Navigator network and system is that we in the ED we can get, it's actually much harder to start people who are in active use and are just getting started on buprenorphine, and we can do that really well and really easily in the ED. And then primary care just has the job of doing maintenance. And so, as you're talking about training and all that, it's fairly simple to refill the meds and reassess and continue that follow-up care becomes much easier when the ED has the capacity to kind of do the start, which can be the biggest barrier for many patients, is getting that initial start on the medication, so the training is actually pretty straightforward.
Yeah, that's the agreement we have with our two. We have 3 outpatient clinics now, as well. We're happy to get folks started, and as long as they help us with a close follow-up. So we recommend follow-up within 24 to 72 hours. So
yeah, the upkeep is real, and that is actually why we have we call them regional directors, coaches on staff at California Bridge. We understand that it's not just a one-time training and then we go away and you have a highly functioning MAT program forever. So Lupe, definitely get in touch with me. I'll put my email in the chat here. I would love to connect you to Raul Ayala or Race Vora, who are our people in your region.
Well, thank you so much to everybody on this presentation today, on this call. This was really fun. Josh and I, we love doing this and being able to really tell as many people as we can about this model, because it works so well.
Yeah, thank you for joining us. It's really, really great. It's nice to have, it's so well attended and so many people are just excited about this. Fantastic.
Thank you. All right, Caroline, I think we can go ahead and end the training. Have a great day, everyone. Thanks, Josh and Ariana, for staying a couple extra moments. Nice work, everyone.